Welcome to Season 4 of Public Health on Call, a podcast from the Johns Hopkins Bloomberg School of Public Health. I'm Josh Sharfstein, Vice Dean for Public Health Practice and Community Engagement and a former Commissioner of Health in Baltimore City. Our goal is to bring scientific evidence and experience to current topics in public health through engaging interviews with scientists, community leaders, policy experts, public health officials, clinicians, and more. If you have ideas or questions for us to cover, please email us at publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes.
Hey, Public Health on Call listeners. You're invited to join us virtually on Wednesday, November 10th for the 2021 Bloomberg American Health Summit. This year's theme, Public Health Visible. You'll hear from great speakers and take in provocative discussions about major challenges facing health in the United States, including COVID, overdose, violence, climate, health problems facing immigrant children, and the broken food system. You can join the live stream at 9:30 a.m. Eastern Time on November 10th. Learn more at americanhealth.jhu.edu. That's americanhealth.jhu.edu. Today, we're bringing you another Friday Q&A. Dr. Amesh Adalja from the Center for Health Security and Dr. Josh Sharfstein answer your questions sent to our email address, publichealthquestion@jhu.edu. Let's get right to it.
Dr. Adalja, thank you so much for coming back to Public Health on Call to answer some questions from our listeners. How are you doing?
I'm good. Thanks for having me back.
You still out there seeing patients in hospitals who have COVID?
Yes, I just worked yesterday, and there are still primarily unvaccinated individuals getting hospitalized with COVID. I think it varies geographically. What I see now is a lot more in rural areas where there may be lower vaccine uptake versus urban areas where vaccine uptake may be higher or there may be higher levels of immunity, but it's still disruptive.
How are the staff doing? It's been quite a long time.
I think the staff are burned out. There's lots of staffing issues. People are leaving kind of acute care. Lots of nurses, for example, are leaving the emergency department to go work on the IV team or to do telemedicine. They're looking for less acute jobs. And I think that's going to be something we have to deal with going down the road, that we're going to have less people interested in this type of medicine and healthcare because it was so taxing on them for so long.
It does look like in some parts of the country, the real limitation now is the number of staff, not as much the number of beds.
Right. So a hospital can't really open a bed up for somebody if there's no one to take care of that patient. So staffing has become a major concern. And this is all playing in with the vaccine mandates. Many hospitals don't want to initiate vaccine mandates because they're worried that if the nurses leave, they're going to have even less capacity. So this is a really bad catch-22 that I think is hard to solve.
Well, we got a lot of questions from people about vaccines. So you ready to jump in?
Sure.
All right. First question is, if a vaccinated person is exposed to COVID and does not get sick, when that all is over, does that vaccinated person have even more immunity than when they started?
If the vaccinated person didn't actually get infected, meaning the virus didn't enter their body, enter their cells and trigger an immune response, I wouldn't expect that they have any change in their immunity. But if they had, for example, an asymptomatic infection, you likely would get a boost in your immunity. So it all depends on if you actually have an infection and if that infection triggers your immune response. But if you don't get infected at all, you shouldn't really see any difference in your immunity.
Got it. Next question. Several of my unvaccinated family members have said that boosters are a sign that vaccines are not working. How can I explain that this is not correct?
What you have to really emphasize is that these first generation COVID-19 vaccines aren't magic force fields. They're not bug zappers. What they were designed to do is prevent serious illness, hospitalization, and death. And they're doing that very well. The fact that a vaccine needs a booster isn't that the vaccine has failed. It's just sort of what happens with immunity, that over time, the immunity will wane and you need to boost it back up. Just like the fact that you need a tetanus booster every 10 years doesn't mean the tetanus vaccine doesn't work. Just look at the number of tetanus cases we have in the United States to see how well the vaccine works. So boosters aren't they don't really say anything about whether the vaccine is working or not working. It's just meant to increase the duration of protection. So that's kind of a false way to look at it, to say that this is the vaccine failing.
That's a good explanation. I think people have this idea that vaccines have to be perfect or that people have claimed that vaccines are perfect, when really the claim is that vaccines really help prevent serious illness and death.
Right.
Here's a question. My employer is requiring either vaccination or weekly testing for people who are not vaccinated. How effective is this? Because I don't feel safe being around unvaccinated adults, and I'm not so sure weekly testing is going to help very much. What would you say to this person?
Well, it depends on a bunch of things. One is the frequency of testing, and weekly testing might not be enough in a high prevalence area where there's a lot of infection and there's a lot of unvaccinated individuals. Employers requiring vaccination is the best way to keep their workplace safe, but there are in some circumstances they can't do that, so they're using testing. Testing does reduce the risk. It's not ironclad. And what you can do is maybe think about other policies for the unvaccinated, including having them wear masks or doing more frequent testing. There are rapid home tests that could be done pretty much daily, and that would actually decrease the risk a lot. But in general, it would be great if employers actually required vaccination and they didn't have to go through this cumbersome process of testing. And then you remove that uncertainty that maybe infrequent testing isn't enough in certain high-risk situations.
Right. And the high risk is both related to how prevalent the virus is in the community, as well as the nature of the workplace.
Right. So if you're in a place where there's a lot of infection in the community, or you're in a workplace where it's indoors, where you're unmasked, where you can't social distance, all of that's going to play a role in what type of measures are best in your workplace.
Now to the Greek alphabet. What do we know about any new variants? Are there any new variants of concern that are keeping you up at night?
No variants are keeping me up at night. I think Delta really did a good job of squashing all the other variants, especially in this country, because it's such a fit virus and nothing can really compete with it. It basically erased Alpha. But we are seeing some variants that are being derived from Delta. So you might have heard about in England, the AY 4.2 variant, which some people call Delta Plus, which there's a lot of speculation whether or not it's a more contagious version of Delta. It's too early to know all of that for sure, but you have to remember that there are always going to be new variants that are generated. Most of them are not going to really have a major impact, but it's important that we track them, make sure that our vaccines work against them, make sure that our monoclonal antibodies work against them, and we think about if they're more contagious or not. But that's what the virus is going to do. But right now, none of them are really rising to the level of concern because Delta kind of set a new bar.
Thank you. Very specific question here. If someone is getting a monoclonal antibody treatment that is not for COVID, because there are different kinds of monoclonal antibodies used in medicine, can you still get a vaccine booster?
Yes, you still can get a vaccine booster if your monoclonal antibody is not a COVID monoclonal antibody, because the issue there with the COVID monoclonal antibodies is that the monoclonal antibody basically blocks the effect of the vaccine. So you don't give those things in close proximity to each other, because the vaccine won't work if all that antibody against it is actually circulating in your blood. But it's really important for people that are getting monoclonal antibodies. So for example, my mom takes Humira for rheumatoid arthritis. She got a booster. It's really important because a lot of those monoclonal antibodies are immunosuppressing, and those are the people we want to protect the most. So you should get a booster if you're indicated for one with monoclonal antibody treatment, as long as it's not one of the COVID monoclonal antibodies. There you have to space it.
Thank you. Now some questions about potential adverse effects from the vaccine. So someone wondered whether vaccines might cause partial vision loss. Another person, what about hearing loss? And one person asked whether they could make people who have low blood pressure, POTS disease, get worse. Are any of those known or recognized side effects of the vaccines?
No, none of those are recognized side effects of the vaccine. And it's important to remember that when we're rolling out a vaccine, we want to collect all the information we can. And there's lots of things that might be reported that aren't causally linked to the vaccine, that they may be coincidence, and they take some investigation. But none of those three, ear ringing, eye problems, or changes with blood pressure have been anything that I've seen or seen reported. But I think it's important that we have these broad safety nets to pick up these signals when they do occur and to run them down and see, is this really related to the vaccine? But those aren't anything I would worry about as a problem with these vaccines.
Your overall assessment of the vaccine safety right now?
I think it's extremely safe. I've not seen anything that really puts me off on the vaccine on any patient. I've not seen any major side effects that I've worried about. Obviously, we've heard about things like myocarditis and blood clots, a blood clotting disorder that happens after the Johnson & Johnson vaccine. But again, the risk-benefit ratio in almost every scenario favors the vaccine because we're still in the middle of a pandemic and there's still, over 1,000 people dying every day. So this vaccine still holds up really well when it comes to safety. And there are so many different layers of safety programs in place to make sure that any little thing gets detected and investigated. So I'm very confident in the safety of this vaccine.
Great, thank you. There's a question wondering, once children are vaccinated, should they continue to wear masks?
So this is something that's probably going to go back to your risk tolerance. But in general, I think that there has to be off-ramps for some of these types of policies. And I think vaccination is the best way to reduce the risk of COVID-19 harming a child or harming anyone and reduce the risk of you spreading it. So I do think once community transmission falls, once you've got more people vaccinated and you look at the activity, is it outdoors? Does it involve does it involve unvaccinated people? I think there is room based on your risk tolerance to start to think about when a mask is necessary and when it isn't necessary. And I think that the biggest change factor there is the vaccination status of the person, because we know the vaccines prevent you from getting serious illness. They prevent you from getting infected and they make you much less likely to transmit. So this is going to be on a different time scale for many people, but I think we're getting to those off ramps with more and more people vaccinated.
Follow-up question on off ramps, which is, what about the big off ramp for kind of being in a pandemic society? We do see some significant changes over the last few months. And now with cases falling in many places, how do you see this playing out?
I've always been someone that's talked about the fact that this is going to become a seasonal coronavirus like the other 4 coronaviruses that circulate every year. And there's going to be a baseline number of cases, hospitalizations, and deaths. And the goal was really to remove the ability of the virus to be able to crush hospital capacity. And we're getting there, and we have gotten there in many parts of the country. But I think it's going to take some time for people to learn how to risk adjust to this new virus that's out there. So many people have some kind of hybrid living where they still do a lot of the pandemic mitigation in certain activities and in others they don't. And I think this is all going to be dictated by a person's personal risk preference. But I think the goal is really to turn this into other respiratory viruses that we deal with year in and year out. The vaccine is the best tool for that, but we've got monoclonal antibodies. We're going to probably have oral antivirals soon. All of that makes it much more manageable. But a lot of people, because this pandemic really disrupted their lives and changed all their activities, are going to have a hard time adjusting to the fact that there's always going to be some baseline COVID risk. And I think we've got to do a lot of work to teach people how to risk calculate and to talk about harm reduction, knowing we can't get the risk down to zero, but we give people tools to make their lives a little bit easier to manage with knowing the fact that COVID-19 is always going to be some level risk, but it's going to eventually get to something that's much more like other respiratory viruses that we sort of accept as part of living in a community.
So the right question isn't how do we get exactly back to 2019, perhaps, but what 2022 can look like.
Right. So the post-pandemic world isn't 2019. We can't put this thing back in bats. We have got to find a way forward. It's think about other major public health threats like HIV. We've gotten HIV to a point where it's a manageable chronic disease that we can control, but it's not as if we're back to 1980. We live in a world where HIV is a risk, and we teach people how to mitigate that risk. And I think that's where we have to go with COVID-19.
Thank you. Here's a question from someone who said, I am a COVID long hauler who originally got sick in March 2020. And from message boards that I'm on, it seems that those of us who got COVID in the spring of 2020 may be having more severe symptoms than those who got COVID later in the pandemic. Do we know why that is? Is that true?
I don't know that to be true. I think that there may be some anecdotes out there. And I think this really speaks to the fact that we don't know a lot about post-COVID syndromes and long-haul COVID. We don't have really great definitions. We don't know what clinical criteria qualify someone to be called that or to be diagnosed with that. We don't know if it's all the same thing because so many people have varied symptoms. We're really at the infancy of understanding this. So I think it's hard to say anything for sure regarding whose long symptoms were worse, whose were less, and if that has anything to do with the strains that you were infected with. I think this is just an area that needs a lot more research, a lot more rigor brought to it before we can actually give people guidance that they can actually use. And I think it's important, if you do have long symptoms, to get enrolled at one of those long haul clinics that are popping up all over the country, so that you can be studied, you can be plugged into all of that type of data collection, so that we can get better at taking care of these patients, as there's going to be a lot of them.
One last maybe bonus question for you. The FDA and CDC have allowed some flexibility in which booster shot people pick. Do you have strong views on whether people should do the booster that based on the original vaccine that they got, or switch over? I know that there's some different views on what should be done.
So the mixing and matching, the real value of it is when you use vaccines that are from two different types of technologies. So I don't think there's much value in someone who got Moderna or Pfizer getting the other mRNA vaccine. So switching between Moderna and Pfizer, I don't think you necessarily have to do it. Both of those vaccines are pretty easy to find. Obviously, if you can't find one in your area, it's okay to get the other one. But I don't think there's much value from an immunologic standpoint. Where there's interesting data, though, is in people who got the J&J vaccine getting boosted with the mRNA vaccines, because what they're getting is a bigger than predicted boost. So I have recommended my friends who've gotten the Johnson & Johnson vaccine to get the Moderna or Pfizer as their booster, because these vaccines are using two different types of technologies, stimulating your immune system in two different ways, and you get a bigger boost. I think this is an exciting area, and we may improve a lot of other vaccines by using this type of mixing and matching idea. Unfortunately, it doesn't work the other way around. If you've gotten Moderna or Pfizer and then you get to J&J, you don't get that special boost from the other way around. And this was something they saw also with the AstraZeneca vaccine in other parts of the world, where they mixed and matched AstraZeneca followed by mRNA and got a bigger than normal boost. So I think that's what the data shows, and I think it makes sense to do that.
That is a very helpful answer to the bonus question. Thank you very much, Dr. Adalja. And thank you throughout the pandemic for joining us and just walking through what's on people's minds.
Sure. Thanks for having me.
Public Health On Call is produced by Josh Sharfstein, Lindsay Smith-Rogers, and Stephanie Desmond. Audio production by Spencer Greer, Niall Owen McCusker, and Matthew Martin, with support from Chip Hickey. Distribution by Nick Moran. Production support from Catherine Ricardo. Social media support from Grace Holes Fernandez and Caroline Wong. Thank you for listening.